Tricia Moore?
Yes, I am.
And is it Ronald Calderon?
Yes, sir.
Terrific. Please.
Good afternoon. The Rhode Island Department of Health appreciates the opportunity to tell our 4-year-old story about providing a sound beginning for every newborn baby through its Rhode Island Hearing Assessment Program. Our overall theme is communication and prevention, or the earlier the better, accomplished with our partners, parents, early intervention agencies, visiting nurses, the School for the Deaf, Department of Education, and healthcare providers serving infants and their families. Universal hearing screening is more than a new health standard of care. It represents a major shift in social policy, a smart economic policy that prevents the preventable disability of hearing loss, that is, the lifelong consequences of speech and language delays. Studies have shown that for every dollar invested in prevention, $3 to $4 are actualized in future savings. Society can benefit if its families are safe, healthy, and are able to participate fully in the community. The first public health program of its kind in the nation to apply an innovative technology on a population basis that provides hearing screening for all babies prior to hospital discharge and facilitates referrals to early intervention and other community-based services comes at the end of a 40-year struggle. Hearing loss is the most commonly occurring disability, with a rate of 3 to 6 per 1,000 infants. 50% of infants with hearing loss, however, have no known risk factor. Healthcare policymakers and physicians recognize that the prevalence of hearing loss is a significant social policy issue, and yet, according to a 1997 progress update on the Healthy People 2000 report, U.S. children with congenital hearing loss are still not identified until 2.5 years of age. Delayed detection and intervention result in developmental delays that make it difficult for late identified children to catch up with their peers. Only 25% of deaf high school students read at the 5th grade level or higher. Recent brain research findings indicate that babies are in an urgent use it or lose it mode when it comes to brain stimulation. Our Rhode Island story is a story of prevention, partnerships, and a major policy shift. Babies as young as 6 weeks are diagnosed and are referred immediately into community-based services to assist the family holistically during a very difficult time of grief and loss. Our system makes a difference to the families we serve. Parents must make early decisions that carry lifelong implications. In the words of one mother with 2 children with hearing loss, and quote, "My younger child is doing great and is able to participate in nursery school and wears her hearing aids without a problem. Her older brother was born before the screening program began and wasn't diagnosed until after 2 years of age. I could cry when I look at him and see him struggle to keep up at school. I can't believe how easy it is for him," end quote. Make no mistake about it. The lifelong consequences of unidentified hearing loss are preventable, and our system makes a difference. Rhode Island's success in reducing the average age of diagnosis from 2.5 years to 3 months, and our family-focused intervention system relates to 3 critical success factors. Number 1, creation of a partnership forum through our follow-up committee. Early on, we invited a wide array of agencies from the private and public sectors, advocates, and families to join us in our campaign. Our efforts have resulted in modified insurer policies, education programs for parents, health insurers, and professionals, and a statewide quality indicator system. Number 2, the use of an innovative technology to streamline screening and information management. All Rhode Island hospitals screen babies in their nurseries in less than 10 minutes as part of their daily routine care. And our customized information system provides ongoing benchmarking leading to results such as infants being fit for hearing aids at 6 weeks of age. Number 3, political will and communication make the difference in creating a culture of caring for infants and offer a model of replicability. Our Rhode Island screening law mandates third-party payment, and we also utilize existing governmental programs such as Title V and Part H, now Part C. In summary, Rhode Island's social policy of infants hearing screening, diagnosis, and intervention is straightforward. we either invest early or pay later with lifelong consequences for both the family and society. We in Rhode Island are giving every baby a sound beginning and a lifetime of communication.
Thank you. She's going to ask about your pricing system. I can just hear it coming. Barbara.
That is a very bad reputation now. So I'll preface by saying I have both a hearing impaired son and grandson, so I'm somewhat familiar with the subject matter, and I think it's an exciting program. One of the things I noticed in the material that when you spoke of infants identified with a hearing impairment, that you spoke of amplification, or hearing aids, if you will, but I didn't see any indication of encouragement of either surgical implant options or early signing education for children who had severe disabilities where amplification might not be the answer. Could you comment on that?
Yes. What we really pride ourselves on is letting the parent make the decision what methodology they're going to use. So we do have a book, a guide to parents about choosing the methodology most correct for them. So we like to provide options, so whether you saw it in our material or not, it was in our guide to parents. And that's our biggest issue, getting in and giving the parents as much options and as much information as possible so they can make their own informed decision.
I'd just like to make another clarifying comment. That is correct. We did put in the mean amplification age as a measure of effectiveness, I believe, as part of a standard benchmarking ongoing QA thing that we do. However, the reason we use that, we really use that as a surrogate measure of diagnosis. But I'm so glad you raised this issue because we're continually talking with our families because we absolutely need to be multiculturally based, including all families need to know about sign language, etc. And in fact, we also developed the first resource guide of its kind, detailing national and local resources, including American Sign Language.
Dr. Rhode.
I've got to be missing something here, which is preface to asking what may be an extremely naive question. But I know when my children were born, they underwent a number of tests before we even left the delivery room, including the pricking of a heel for a test to having undeveloped lungs or whatever. Why isn't this, it sounds like a very simple thing to me. Why isn't this not done? Why are you here as an innovation, which clearly you are because it's not done? Why?
I think political will, leadership, and the issue that children are valued in this country needs to be brought home to every state. You're absolutely right. There are hospital studies, what you're talking about is metabolic or hemoglobinopathy studies that look at usual blood issues that all hospitals do. We've carried it one step farther in Rhode Island. We do universal screening on many factors. Hearing is one of them, blood work is one of them. We also look at demographics of families. So we look at all kinds of risk factors in the hospital. I can only answer what we do in Rhode Island. I think that on a national level, there needs to be a governance that children are important. Just like the Older Americans Act, I don't think we have a mandate nationally that talks about children's health the way it should be at this point. But we're working on it.
Again, I just want to make a comment. I think what caused us to be in the forefront of this is that we were also a major research site under the Department of Education. And in 1993, actually, the NIH consensus statement was largely based on the protocols that we've developed. So to answer your question in 2 sentences, I think it was major technological breakthrough that we're using a commercial product that's now available everywhere, and we had some say in terms of its design and instrumentation development. For 20 years we've had a gold standard of auditory brainstem standard, but unfortunately that took 30 minutes. And if you can imagine trying to execute that on every newborn, 4 million kids every year, it's impossible. Personnel costs alone are preventative.
Questions here? I think a lot of us felt listening to you, we could take your program and combine it with the program and help you start in Hawaii. You take that and combine it with a program in Tioga County in Pennsylvania, and then high-end pre-kindergarten program in Georgia. Kids are
We're
having very
working
difficult.
on it.
Actually, we have been talking together already, and in fact, Dale Brady did come to Rhode Island. There are a lot of crossover issues, and we're just so honored to be here, and we're glad that you're recognizing that. There are a lot of similar programs that will help kids all over the country.
Thank you.
Thank you.
Will help kids all over the country.
Thank you.
Thank you.
Will help kids all over the country.